Good afternoon, Lions. My name is Dr. Judy Goldstein, and I am the director of the Lions Vision Research and Rehabilitation Center at the Wilmer Eye Institute at Johns Hopkins. Thank you to John Lawrence, who asked me to give this talk as part of the LOVRNET Symposium today. My task over the next few minutes is to help define for you what is low vision. Defining low vision is not easy because there are many definitions, but most all will agree that it is a chronic loss in vision, and the vision cannot be cured nor restored with medicine, laser, glasses, surgery, contact lenses in any meaningful way. And that loss of vision typically leaves an individual with a loss in visual function or loss in visual ability, the ability to perform activities that depend on vision. So how do we define low vision? How much loss do you need to have before you consider yourself having low vision? Well, the degree of functional loss is related to many factors. It's the magnitude of vision loss. Is it mild impairment, severe impairment? Where is the loss? Is the loss in the center with difficulty reading and seeing detail, or is the loss in the periphery or side vision? Certainly age will dictate one's demands. A younger individual might have more child-raising responsibilities. An older individual might have more work-related demands. So certainly the level of interest in everyday activities is a function of age, which may be a function of one's demands. The level of support we have available to us will often define how the vision loss affects our function and our ability to cope with that function. Certainly with greater support, it makes it easier to function with vision impairment. And other factors such as physical, cognitive, and emotional health factors all interrelate with vision loss. So now that we've defined low vision, how do we measure low vision? Well, we do it typically one of three ways. We may use patient self-reported questionnaires, something that the Lions are quite familiar with, essentially asking patients questions to rate their ability to perform everyday activities. We could do it via performance measures, watching an individual do an activity and measure how long it takes them to do that activity or how many mistakes they make when they do that activity. And something we commonly do in the clinic is we measure low vision by assessing impairment findings. There are generally three impairment measures that we use: visual acuity, contrast sensitivity, and visual field. Distance visual acuity, the most common and familiar measurement to many, is a measure of central visual function. It uses optotypes or characters that we ask that individuals resolve. So it's basically a test of visual resolution. And the findings we report from these tests are familiar to most of us as 20/20, 20/40, 20/80. This chart in front of you, the Etdrs chart, measures visual acuity or resolution from 20/20 to 20/800. Typically, people who have problems with visual acuity or decline in visual acuity have symptoms of difficulty reading or trouble seeing detail. When visual acuity is on the much poorer side or profound loss, we will use lower levels or ultra-low vision visual acuity charts. This advancement in the field has made it possible to precisely estimate acuity at lower levels, which becomes important when we talk about new strategies or trials to improve individuals from blindness to vision loss. For us every day in the clinic, we typically see patients with mild to moderate visual acuity loss, people who have usable or functional vision that can be enhanced, usually up to the 2200 range. We do have patients who fall into the severe, profound, and totally impaired, and for those individuals, rehabilitation strategies will vary. Contrast sensitivity, though not a typical measure obtained in general ophthalmologic exam, is an essential measure in the vision rehabilitation evaluation. It's the ratio of the luminance of an object to the luminance of the background, and contrast sensitivity can be thought of essentially as the person's ability to distinguish an object from its background. It strongly contributes to real-world perception and function in a number of really critical ways, especially difficulty with recognizing faces or trouble driving at night in the rain. While contrast sensitivity is known to decrease somewhat in normal eyes starting at ages 40 to 60, the presence of ocular disease often results in further contrast sensitivity declines. The final metric we use in the clinic commonly is assessment of peripheral visual fields. We do this when we watch a patient navigate back to the clinic. We test it more precisely if we assess it with some object, often the periphery. When can the patient see it? When can they not see it? We can do this with mapping it out on a big screen. We can hold our fingers up in the periphery and ask the patient to count them. We can do it in a more systematic way using testing, such as Humphrey or Goleman visual field testing. Peripheral fields is very different than measurement of central visual fields with central visual acuity. So evaluating the patient when we often watch them may be when they're reading or they're reading slowly. In this particular case, this is a sample of a peripheral automated Humphrey visual field. If you pay attention to the crosshairs in the center, we see that there are darker areas near the center and just way below center. This is an estimate of an individual's central 60 degrees. So below the line of sight, the patient does not see well, but above the line of sight, they see fine. This is an example of a Goleman visual field. The Goleman visual field provides the advantage of being able to measure out much further into the periphery, approximately 90 degrees to each side. It is administered manually by a technician, and the technician brings the light from seeing areas to non-seeing areas and non-seeing areas to seeing areas, essentially mapping out rings of places where one can see and not see. This gives us a much more functional assessment of the patient's visual field. This is a good example of a Goleman visual field, where the center, represented by the opaque green circle, is an area where the patient has reduced central vision. But the rings around the periphery show spared peripheral area. So mapping out an individual's visual field tells us where they see and where they don't see. So in summary, low vision is certainly when vision loss affects the ability to perform everyday activities. But it's the psychophysical measurements that we obtain in the clinic, the acuity, the contrast in field, that helps us define low vision in a categorical way, that helps inform us about how their impairment affects their function. These impairment measures have certain limitations in that they don't let us know about the goals and tasks of interest to the patient, and they don't tell us about the physical, cognitive, and emotional concerns that patients have. So it is the combination of all of these factors that helps us truly define low vision. Thank you for your attention.